A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Good evening, friends. Welcome to the 58th webinar of the CAHO-ISQua International Webinar Series. On behalf of the Extended Governing Committee of CAHO, our President, Dr. Pereira, I would like to welcome all of you who have joined this wonderful session today, for taking the time and for being here. As you're aware, CAHO is a not-for-profit society established to promote quality, patient safety, and accreditation in the region. We are delighted to have with us today one of the most prominent faces from India to be moderating this particular session on patients for patient safety, Dr. Ravindra Karanjekar. Dr. Ravindra Karanjekar needs no introduction. He's a very seasoned healthcare leader with extensive experience in hospital administration, quality, and operations. Currently serves as the CEO of Kiran Hospital. He has held very senior roles at Jupiter Hospitals, Seven Hills, and Global Hospitals, a former chairperson of NABH between the years 2010 and 2014, and also contributed to NABH as an assessor from 2008. He has contributed very significantly to advancing healthcare quality and accreditation in India. He also served on the Management Council of Maharashtra University of Health Sciences, a great friend of CAHO, personally to me, a very good friend. So it's my privilege to welcome him to moderate this session and also to welcome all of you once again to the International Webinar Series of CAHO on patients for patient safety. I now hand over to Dr. Ravindra Karanjekar. Over to you, sir.
Thank you, Lalo, and thank you, Kaho, for inviting me to moderate this session. We have a great speaker today, Tiberius Pereira. He is the co-founder of Patient Safety Ireland, and for almost 11 years under the World Health Organization. The aim of this organization is to engage and empower the patients and families to be active partners and advocate their own care. The framework of this action of global the framework for action for this global patient safety action plan is being adopted by the Department of Health and Safety Ireland and is being advocated across the world. Today, we will have the words from Mr. Pereira regarding this. His extensive experience and his way of explaining the whole thing is so nice that probably we'll take home a lot of messages from today. And I again, once again, thank CAHO for being the partner in this international webinars where a lot of people can engage themselves into the patient safety. If we see today, the quality revolves around patient safety. If there is no patient safety, you cannot vouch for the quality. So patient safety and quality go synonymous with each other. And for this patient safety part, we would like to learn it from you little more, sir. So hand over to you, sir. Thank you.
Thank you very much for those very kind words, Doctor. I don't know, I've got a lot to live up to there. I'm just trying to share my screen. Oh yeah. Can you let me know when you can see my screen?
Yeah, we can see your screen.
Okay, great. Thank you. So my name is Tiberius Pereira, Tibbs Pereira. And yeah, I'm a founder member of Patients for Patient Safety Ireland, as Dr. Karanjeka said. We most of us have experienced harm, most of us in the organization, but we're a tiny organization compared to you, so I don't know how much I'm going to be able to share with you that you don't already know. And what I see out of this is, I'd really welcome the opportunity to collaborate with CAHO. I think there's a lot that we can learn from the great work you do. So thank you very much for the opportunity. And let me navigate. As you heard, we're sorry. As you heard, we were formed just around 13 years ago under the World Health Organization Patients for Patient Safety program. And you see the bottom left of your screen, you'll see the link. I don't know how many of you might be familiar with the program itself. But the main thing, there were three main kind of some broad aims for the program. Firstly was to engage and empower patients and families, and we've kind of learned a little bit or a lot along the way. And I'll kind of provide you with some updates about the things that we've learned and some of the things that we're up to more recently. Key to what we do is we work in partnership with health professionals and policymakers around making services better for people, for the public. So we collaborate quite a lot. We're not a pressure group. Every now and then we will kind of alert people and we will raise awareness of some issues, and sometimes that does make healthcare professionals and the Department of Health and people a little uncomfortable. But overall, we work in partnership. We always share information very closely with everyone. And kind of our main aim is there's a lot of really good policy and strategy around. But quite often, particularly now, people don't really experience the difference when a new policy is announced. People on the ground, members of the public, don't actually experience that difference. And so, there are a lot of people who are disaffected, people who feel that they're left behind, that policymakers don't really understand them. And quite often there's that gap, so we try and identify where we can address that gap between policy and the experience of people in general. So our goals in general are to make sure that people feel better engaged, whether they're patients, families, overall in communities, so they can actually play an active role in their own care. I think, it's probably more appropriate to a large country like India, but in Ireland as well, there are we need to make sure that everyone feels like they're the active partner. So that's more about self-awareness, more about self-management. As we're able to move more services and care into communities and away from big hospitals and so on. There's a large rural population in Ireland. Just making sure that people like that don't feel left behind. We want to make sure that when policymakers are thinking about things and thinking about how to enhance services and thinking about care in general, that they hear the voices of patients and people. And quite often, people feel left behind, particularly people from more marginalized areas, people living in poverty, people who might be experiencing homelessness, lots of other people who feel that they are excluded. And those people are generally low on confidence as well, so their voices are rarely heard. They don't typically, people like that don't typically engage in kind of policy and planning and so on. And finally, we want to kind of create that overall environment to improve outcomes really, and to improve people's overall health. So it's not only about healthcare, it's about their overall health. And I'll talk a little bit about more about that. And it's about building these better partnerships around, so building large communities. So our values, firstly are, it's kind of focusing on patient safety, but patient safety covers a lot of things. So it's making sure that we start thinking about patient safety. We start thinking about empowering people to be active partners in their care. We always remain independent. So we're a group of complete volunteers. Many of us have regular full-time jobs as well. So we don't take funding from any organization. If we don't take we don't we're not funded by the pharmaceutical industry. We're not funded by anybody. If we do get an engagement that requires us to travel, we just ask for our travel costs to be covered. Everything else we do on a voluntary basis, and we really try and work as agents for change. So, try and understand, the main blockers to people accessing healthcare and people actually who do experience good health outcomes. We're trying to identify where we can actually make those changes and ask for and demand those changes. And finally, we are completely exclusive. We're completely inclusive. So it is about respecting every person, and we don't regard ourselves as particularly representative of every patient because that's not possible. So I'll talk a little bit more about what we're doing in around the area of inclusion. So we have really good partnerships with the Department of Health up to very senior levels within the department. The Health Service Executive, which is like kind of the equivalent of the NHS in the UK. So they're the ones who actually deliver services in primary and in acute settings and also in social settings. Um, there's a Health Information Quality Authority, which is a regulator. There's a Medical Council of Ireland, which is a regulator for doctors. Um, there's the International Society for Quality in Healthcare, which is ISQua, which you know, and there are royal colleges as well, which act as, which set the standards for physicians, for surgeons, and so on. So we engage very closely with them around different topics. Can you hear me okay? Is that okay? Yeah. Um, and we also engage with a number of advocacy groups as well, and I'll talk about that. So it's actually a much larger list of organizations that we engage with. Some of them I'll mention in the next few minutes as well. So, um, last year there are probably around 20, only about 22, 25 of us in the group. And last year there were over 200 unique engagements. So those are 200 projects, and each of those projects would typically require a number of separate meetings and, specific engagements as well. So, we think our impact is kind of quite large compared to our size. As was mentioned, there's a World Health Organization Global Patient Safety Action Plan. I don't know, you might be familiar with it already. Um, but it's kind of a lot of it is around the vision of a world in which no one is harmed in healthcare. And every patient receives safe and respectful care every time and everywhere. And they have a 7x5 matrix, which is a framework for action. And we would kind of engage across most of those in one way or another. But a key part of that, if you look at the triangles at the bottom, the green triangles on the bottom right, you see patient and family engagement is very important in all aspects of healthcare policy development and delivery. In Ireland, the health service has produced a patient safety strategy. We had a lot of input into that. The forward for the strategy was written by our chair. And kind of, they identify the top tips. They also identify the common causes of harm. And number one was about engaging patients as partners in their care. And there's a lot there about patient engagement and communicating with patients. Some fairly basic things that are prioritized in the strategy. And on the right hand side, the hexagons, you can see the different areas as well, different ambitions the strategy has for delivery. Now that's a little bit out of date. They're in the process of producing a new one, but I don't think it'll be hugely different. It'll be a little bit more ambitious than it was than it has been until now. And so in 2022, the WHO had the theme for World Patient Safety Day was medication without harm, and we got quite involved in that. It was the first time we actually got involved in some really proactive work, and we adopted the WHO action areas, specifically highlighting the three areas of highest risk, which was polypharmacy, high risk situations, and transitions of care. Now, as a relatively small group, there was a limit to what we could do. So the main thing we decided to work on was to focus on encouraging patients to keep a list of their medicines, particularly those who were in receipt of a number of medicines as well. So there was a table that was produced, which you will see in the kind of bottom of the screen, which enabled a patient, and it was a paper leaflet, if you like, that had been designed a few years earlier. And so we got those leaflets to go out to every pharmacy, out into hospitals, out into GP surgeries, wherever we could. And but that wasn't really satisfactory. When a new health app was produced, that was released at the start of this year, in February of this year, we had a lot of input into that app, and the first thing that was released in the app was that medicines list as an app. So you can see a little screenshot of it there. So that everyone can keep a track of what they're doing. They can also keep track of they can also list their allergies. So if it came to an emergency situation, the app could be opened to show exactly what medications people were on, their allergies and so on. And we're going to continue to enhance that to provide even more empowerment to people. The big thing was in 2023 when the theme for World Patient Safety Day was engaging patients for patient safety. As I said, as a small group, we had to focus, we had to decide what was the small thing that we could do. When we thought about involving patients and so on, we started to wonder whether the model of patient representatives was really fit for purpose. So we decided, we kind of, when we want people to be more active and thinking about co-production, so looking at the box on the left-hand side, thinking more, engaging more in co-production and co-design, or actually just moving from the bottom towards the top of the ladder into better engagement in general, we decided that it was important, and the triangle on the right, we decided that it was more important rather than us feeling like we were more part of healthcare delivery. We decided to focus more on making sure everybody felt like an active patient. So even in our own experience, when we first started in 2013, there was a lot of that zero engagement that went on. And because there was a lot of pressure in general within healthcare to engage patients, we found that we were being engaged in different committees and meetings because, as I said, we don't charge for anything, right? So we become a free resource. And we found that people were including us to just say they had a patient partner engaged, but they didn't really, our input made no difference whatsoever. Um, we then moved on to the top two here, uh, but we went on to a fairly dangerous kind of phase where everyone felt that they were engaging patients and they really intended to engage and they included us a lot. But in the end, like what we said, wouldn't make the final report or anything substantial that was important to us would get diluted. Without any real discussion, our voice would be drowned out by the voices of healthcare professionals. So essentially, although they felt that they were including us and they wanted to include us, the end result, actually, we may had very little impact or minimal impact. And that was disappointing for us. As I say, we give up our time on a voluntary basis, and it's actually very difficult to provide people with feedback to say, look, we don't think that, the substance of what we were saying has been included. Um, and kind of increasingly, we're getting to that top right-hand box, which is where we feel our voice is respected, and our decisions are based on consensus. So we don't expect everything we say to be included in the final version of a report, but we do expect a discussion around it so we can then arrive at a consensus. And that's with patient representation. However, what our aim is when we thought about engaging patients was that it's important to empower and engage every person, every patient, and every service user to be an active partner. And that needs to be experienced by the person in every interaction they have with anyone in the health services. Furthermore, I'm sure you all know about the social determinants of health. And, I mentioned already that people who are in the most marginalized areas, or in the most marginalized communities, actually receive the worst outcomes, and and I've got another slide around that as well. Um, so um, what we really try and think about is how do we make sure that people like that are included? And how do we address those social determinants of health? And basically, um, someone's overall well-being, health and well-being, is determined very little actually by healthcare, by the health service. Particularly in those disadvantaged areas. As an example, there are fewer GPs per 10,000 people than in a more affluent area. Um, and so, so we're very, very conscious of the inverse care, and we're really conscious of our role as patient representatives, who actually most of us can engage on a voluntary basis because we come from a better off area, we come from a better off background. I can take a bit of time off work because I just have that flexibility at work, and not everyone has that. Not everyone has that ability to do it, So someone who might be living in poverty is more worried about getting enough money so they can afford the next meal, or get clothes for their children or something like that. They don't have the luxury that I do to be able to do this, for example. I don't know how many of you know London, but I'm from London, but although I live in Ireland now, um, but I don't know, if you're familiar or if you know the underground system in London. And you may or may not have heard of Oxford Circus, which is right in the centre. I don't know if you can see the pointer on my screen. It's where the red, brown, and blue lines kind of intersect. So life expectancy around Oxford Circus is 96 years for someone there. If I look 5 miles away onto the black line, which is called the Northern Line, and if you look towards the top, the bottom right-hand side of your screen, you might be familiar. I'm assuming because you're in India, you've heard of the Oval Cricket Ground. Um, so around the Oval, it's 5 miles between Oxford Circus and the Oval. Um, and the life expectancy is 78 years. There's an 18-year difference between the life expectancy, just 5 miles apart. If I highlight another area, and that around the Oval is an area of very high child poverty. Obviously, in around Oxford Circus, it's kind of it's very low child poverty. It's one of the better off parts of London. If I look again, you can see the river kind of working its way along. If I just look at, where there's a blue line going across the river to kind of the northwest of the blue line is a place called Pimlico, which is where the Houses of Parliament are, and Big Ben is not that far away, and so on. So that's a very well-off area, and the life expectancy is 84 years. But you go across, and that's 1 mile away uh, to the south of the river, which is just you follow that blue line, and you get to a place called Vauxhall, which is an area once again of high child poverty, and life expectancy drops 6 years to 78. Now, none of that is actually massively influenced by the health service, right? It's kind of someone's background, it's where someone is born, it's the child experiences grows up in poverty and is that kind of follows them for the rest of their life. It's quite difficult, when they're, they might be developmentally challenged. They might be low in nutrition or nutrition that's not particularly nutritious, and so on. So, you're getting to areas, and that kind of life expectancy follows them no matter what. So, we're starting to think more and more about addressing all those social determinants of health, not only the health service. So this needs to be more of a society kind of response to things. So what we've done as a result is, we formed an initiative or a program called Patient Empowerment, and you can see the logo at the bottom right. And the reason why Patients for Patient Safety Ireland did that is because we have our own terms of reference and so on, and we can't expect a lot of these other organizations to just follow our terms of reference. So we created a new kind of program. It's just a brand. And we engage in partnership with probably around 40 other groups. There are some that are more about specific chronic conditions like the Irish Heart Foundation and the Irish Cancer Society. There are some around mental health. Part A Point is something. There's a minority in Ireland called Travellers. Some of you may know Travellers, and there's also Roma, which are gypsy population, and those people actually are excluded from society. They experience worse outcomes, much higher rates of suicide, and things like mental health issues compared to the general majority population. So we have them on board as a really important partner. There's Cordia, who represent migrants. There's a decision support service, which is about supporting people, particularly with mental health issues, on making decisions. There's a patient advocacy service, which is a Department of Health funded organization. And you'll see there are a number of different groups represented. There's also European Health Futures Forum, which is a much bigger organization based across Europe as well. So we formed this alliance and this collaboration with a number of other groups in order that we can be more representative, and the work we do is then amplified by all these other groups, and we work very much in collaboration. So a lot of them provide really good health education around different conditions and around different scenarios to support different people across society. Ireland is actually generally a very highly educated population. As a country, it's a very well-off country as well, and so people. It's a very small population, just 5.5 million, and growing quite rapidly, but it's a small country. And a majority of patients do want to be treated as an active partner in their care, but they don't feel that they are doing that. They feel that too much jargon is used, that people speak a bit too formally, and they don't take time to explain things. So, what we've done is we've put together the patient empowerment program, and the vision is to ensure that there is true decision making, and it is genuinely patient centered. That we want to make sure that every person feels like they're regarded as an active partner in their care. And the overall aim of the program is to empower every person with the knowledge, skills, and confidence to be an active partner and an advocate for their care and the care of their loved ones. And kind of we want to make sure that every patient service user uh, and carer, as well as every member of staff, really experience the difference. So, this is kind of the weakness of having the big downside of having patient organizations or patient representation is that you start to build another organization. If you build a partner or patient partner organization within the health service, that becomes another organization. We want everything to be experienced by every patient, and we want every practice to be practiced by every member of staff across healthcare. Now, as I mentioned, it's a society thing, so we want to make sure that health literacy and patient empowerment is included in education in secondary schools, from secondary schools onwards. So everyone kind of grows up knowing how to engage with the health service and is familiar with some of the terminology. So there's a subject called social, political, and social personal and health education, which is a compulsory subject, and we're asking for health literacy to be included in that subject. Obviously, through the health services as well, particularly focusing on community and public health. We find that a lot of the time when people talk about the health service, the focus is usually on hospitals, and hospitals are actually not the ideal place to empower people. People might be feeling very sick, they might be feeling very vulnerable, and it's the last opportunity. It's if you're trying to empower people there, it's too late, really. And finally, in communities as well. So, in our libraries and citizens' information centres and community centres, through pharmacies, and so on. And we're not calling for people to become experts, but we're just asking for people to understand to gain some basic skills and confidence on how to access healthcare, how to navigate services, some basic questions to ask, some basic self-management tools and practices, a lot of which is provided by the really good advocacy groups. And finally, how to escalate, if you do have a concern. So there is an open disclosure policy in place. There is a patient advocacy service who provide really good guidance for anyone who has a concern or a complaint. And finally, signposting people to patient information education resources from trusted sources. Because there's so much misinformation and disinformation and conspiracy theories out there that it's really important that we're signposting to the right, to trusted and reliable sources. So that's kind of to counter a lot of that, a lot of the malign influences that we see around the world. This is purely a patient-led initiative. We and we are well engaged with a lot of groups, a lot of the regions, the health regions here in Ireland, and we are basing it on a European Patients Forum campaign, which was actually released 10 years ago. Where we're really trying to make sure that at an individual level as well as an organization level and a policy level, that people feel supported and people are supported as active partners. And there are kind of there are five aspects of patient empowerment, health literacy being the most important one, but also we talk about self-efficacy, self-awareness, confidence, and coping skills. So I think that's all I have for you. I don't know if that makes any sense whatsoever, but I just thought this was, and thank you very much for the opportunity to share. My contact details are here. You can also find me on LinkedIn if you look up Tiberius Pereira or Tibbs Pereira. You'll find me quite easily on LinkedIn. Thank you very much.
Thank you, Mr. Pereira. Yeah, it was a wonderful presentation. I must say we have learned quite a lot of things from this. I would like to have one question from myself, that what is the role of AI now in this patient safety area?
Yeah, it's actually a really interesting question. Now, in my real life, I work for in my professional life, I work for a technology company, and my area has been for the last 15 years or so, it has been around data and AI. And I think there is a lot, you know, there are a lot of risks to AI without a doubt. I think I think there's AI and there's AI. There's a chat GPT kind of AI. But there's also the AI that can be used on, with scans to spot tumors and so on, and those are, that's AI that can be really useful, once how it works. I think that's the important thing, is to make sure that whatever AI you're using is trusted. However, I think, the big opportunity ahead of us is not actually about AI. It's about using good old-fashioned big data analytics, for example, to understand the experience of those people in marginalized areas, to really understand, what are the blockers to people like that accessing healthcare or living, healthier lives, or just giving people the opportunity to um, to improve their health. All right. So, and then understanding, for example, once you've identified, once you've understood those blockers, sometimes it's as simple as transport, right? Someone living in a rural area not being able to get to an appointment. So sometimes it's actually very, very straightforward. And then understanding at a society level what interventions or what support you can offer, those people, and you can use data, and you can use data analytics to identify a very small number of people, very small cohorts of people who have similar issues, and then have packages that will help to address those issues. And it's not just about healthcare issues, right? It's about societal issues, it's about housing, it's around deprivation, it's around things like that. And I think that's the big opportunity ahead of us. And those techniques, the way that Google or Facebook can actually provide you with ads that are so tailored. If Google can do it, then healthcare can do it, and society can do it as a whole. So I don't know if that answers your question, but I do think that there's
Yeah,
a
yeah.
much bigger
Thank
opportunity.
you. Thank you very much. Uh, you were talking about the life expectancy at London, various peripheral areas and other things. Do you really think that the change in habits in the urban population may help them to increase the life expectancy?
I think um, I think if health in general, not just healthcare, but if someone's health in general is seen as a society, is something for society to help people with, um, then absolutely, some of the things that affect people's life expectancy, for example, so looking at the London example, is purely where someone is born, right? And the kind of experiences they have as young children. And the kind of access they have to care as a child. So I think with the right interventions and with the right response from society as a whole, it's very possible to increase someone's life expectancy. Yes.
Uh, one more question is there that there is a huge impact of uh, marketing as well as people promoting their own products. And what happens is that the patient or patient's relatives are very much confused. In that situation, they have to have a faith in doctor, but with the type of little knowledge through the Google doctor or chat GTP or anything, uh, they are really confused whether doctor is telling right or wrong. And then they start shopping around, they talk with so many people, they feel something is not given properly. So in this situation, how do we educate the patient?
Yeah, that's a much bigger one, right? So it's we talk about giving every person, before they're a patient. So even at schools, the knowledge, skills, and confidence, so they can make their own decisions, so they can they can be active partners. And part of that is about things like healthy eating. Part of it is about, smoking. Part of it is about, just living healthier lifestyles. Now, they can choose to do whatever they want. Uh, but I think it's important, right at the start from schools that people are given, um, that knowledge, skills, and confidence so they can make their own decisions, but also so they can make their own decisions from an informed perspective. So understanding, what are the trusted sources of information, so using those trusted sources. So we only use trusted sources. We go to the WHO, we go to the CDC in the US, we use the Institute for Healthcare Improvement, ISQua, and places like that. So it's really important that we provide people with that knowledge, that skills, and that confidence.
Uh, the role of hand washing, role of medication errors, and other things you talked about. But these all are the chain of events actually, right from writing the medicines. to the getting it to the patient. And also one of the things which I followed and we did a good audit on that is the time when the patient gets the medicine, because lot of big hospitals, I run a 1200 bed hospital, so lot of big hospitals, it takes lot of time by the time patients get the medicines. You get admitted, but it takes 3 to 4 hours. So the acute conditions, unless admitted in ICU, does not get proper treatment, and the patient relatives feel that they are not being treated. So communication with the patient becomes a very important factor, and patient has to understand it. Then only probably the patient betterment will happen.
Yes, so two things. Obviously, there's an internal, it's important for the health system and the health service to be able to get the medications to the patient, in a timely manner. But when things, in healthcare, some things don't, not everything works perfectly, right? Things can go wrong. There could be structural issues, there could be a number of different issues. So I think, as patients, most people understand that healthcare is risky, that not everything is going to work smoothly, that there isn't an infinite budget to get everything working, perfectly right. And every now and then things go wrong, right? There are adverse events, patients are harmed. And one of the big things we do, actually, I have done since we were formed, 13 years ago, um, has been around open disclosure. So, communicating clearly and honestly with the patient in a timely manner. So, when something's not right, actually explaining to the patient. And, we found, we know, research has shown that, when people feel that they're trusted, when people feel that they're being kept informed, that uh, they have trust. It builds trust in the system, and people tend to be understanding. Um, but if people feel that they're being lied to, then they become more susceptible to the going to Google and looking for, easy cures or easy responses and so on. So the whole idea of communication and, honest communication and treating the patient, or the person with respect and, being open and honest is really important. I don't know, does that answer your question or does that address
Yeah,
it?
yeah,
Yeah.
that's fine, absolutely. Over to you, Lalu, madam.
So, Ralu ma'am, she has to go somewhere, so she's not here. So
Okay,
I'll close this session. So
okay.
thank you, Mr. Tips, for your inspiring insights and for reminding us that true healthcare quality begins and ends with the patient. Sincere thanks also to Dr. Ravi for his valuable contributions and for leading today's discussion. So today's session truly reflected the sense of patience for patient safety, a movement that continues to guide us towards safer, more humane, and patient-centered care. And we are now pleased to present a certificate of appreciation to Mr. Tips in recognition of his invaluable contribution to today's session and his continued commitment to advancing patient safety globally.
Okay, thank you.
Thank you very much. That's much
Thank you, Mr.
appreciated.
Thank you,
Pereira.
everyone,
It
on
was very
behalf of
nice.
ISQua and ESQua for joining us. Let's continue to work towards
Yes,
making healthcare safer for every patient everywhere.
yeah. Cow is doing the great job in this. And I
Thank
think
you,
Mr.
everyone.
Pereira has given the highlights about the patient safety. So thank you very much.
Thank you very much for the opportunity and the certificate. That's much appreciated.